Hello and welcome to another lecture of Psychology 101. This is your instructor, Dr. Shadi Bashai, and in today's lecture, we will discuss the second part of the unit on psychological disorders, which corresponds to chapter 15 of your textbook. So here we go. So last time we spoke, we talked about the DSM, and we went through a history of abnormal psychology, if you will, and how models of psychopathology have changed or stayed relatively the same over the course of the history of psychopathology and abnormal behavior. Today, and in the next two lectures, if you will, we will talk more specifically about specific diagnostic criteria within the DSM. So one of the very first and one of the biggest diagnostic criteria or diagnostic categories in DSM are anxiety and anxiety-related disorders or conditions. So here we go. Anxiety is defined as a state of alarm or this general sense of apprehension or foreboding that is specifically designed to tell you that there is some kind of threat in the environment. That is, anxiety is this tension or this feeling that you get when your brain perceives there is some kind of threat in the environment. And anxiety is the body or the brain's way of preparing you for this threat. And it prepares you to either fight, flee, or freeze in that particular situation. So overall, the feelings or the sensations of anxiety are extremely evolutionarily adaptive. Okay, so you can probably imagine how adaptive this alarm feature of threat is in something like the savanna in our early evolutionary history. However, given our current climate and given our current environmental context, there's not a lot of predators out there, okay? Yet people who experience bona fide anxiety disorders, their body responds as if there is a natural predator out there in the environment. So this very evolutionarily adaptive function of feeling anxious becomes disproportionate to what the context actually is. Amongst people who have a diagnosable anxiety condition. So they experience anxiety a lot more intensely than they need to, sometimes even when they don't need to experience anxiety given that there is no threat in the environment. And then finally, they experience these anxiety or these features of anxiety for much longer periods. Again, much longer than is needed to deal appropriately with a threat in the environment. Okay, so that's what happens when a very adaptive mechanism, such as feeling anxious, kind of runs amok, if you will, and the mechanism starts to fray function, becomes less functional than what it was designed for. Anxiety disorders, generally speaking, and again, there are a number of anxiety conditions within the anxiety disorder category, but overall, the anxiety disorders, all of them, are some of the most prevalent psychological conditions of North America. And in fact, as much as 18% of people, of the population, will experience a bona fide or a diagnosable anxiety condition at some point in their lives. Okay? Part of the issue, too, is that anxiety is often comorbid or co-occurs or comes together with a number of other diagnosable conditions. One of the very close conditions or close diagnoses very often comorbid with anxiety disorders is, of course, major depressive disorder or depression. And in fact, the overlap between them is anywhere from 65% to 75%, meaning about anywhere from 65 to 75% of people who have an anxiety condition will have a depressive episode, and vice versa. About anywhere from 65 to 75% of people with depression will have some kind of an anxiety disorder to go along with that. And we call that comorbidity, when two or more conditions are actually present. One of the first anxiety conditions that we will discuss is a condition called Generalized Anxiety Disorder, or GAD. Here are the DSM-5 criteria for GAD. So I want you to just take a minute here to look over this criteria. And when you've had a chance to examine this criteria, you'll probably notice that the hallmark features of generalized anxiety disorder is the experience of this uncontrollable and very debilitating levels of worry. Okay? And the person typically has a very, very hard time controlling this worry. And the DSM gives very clear criteria about how long the person needs to experience this excessive worry or anxiety, and that's about 6 months. And it also presents you with a number of other features that need to be present in order for a generalized anxiety disorder diagnosis to be reached. And these include about three or more of the following, including restlessness or feeling keyed up or on edge, being easily fatigued, having a hard time concentrating, irritability, muscle tension, sleep disturbance, you name it. Okay, so it's the experience of this very excessive and uncontrollable levels of worry, and the worry typically is about a number of features or number of aspects of people's lives. So when people have or suffer from generalized anxiety disorder, their worries are often about school, they're often about work, they're often about finances, they're often about relationships. So there's no particular theme to this worry. It's just the worry is extremely excessive and very difficult to control, happens within 6 months, and comes along with these bunch of symptoms. There is panic disorder. Okay? And panic disorder, according to DSM-5 criteria, is basically the experience of recurrent and I think this word needs to be underlined, unexpected panic attacks. And I'm not sure about you, but panic attacks themselves are extremely prevalent conditions. Most people that I've talked to, including myself, have experienced a panic attack. But the experience of a panic disorder is the experience of panic attacks, and the experience of panic attacks that coincides with a fear that the panic attack will happen again and again and again. And that fear starts making you change your behavior a little bit. So now you start avoiding circumstances where you think you might get a panic attack. So it's not just the experience of panic attacks, it's the fear around panic as well that would meet diagnostic criteria for having a panic disorder. Okay, so some of the features of a panic attack include heart palpitations, and the DSM lays out all of these different symptoms. So heart palpitations, sweating, trembling, shortness of breath, fear that you're going crazy or fear that you're dying. So many of these thoughts about, there's something wrong with me, I think I'm having a heart attack. And all of these symptoms of a panic attack are quite intense. So people, their anxiety is usually through the roof, 100 out of 100, if you will, which is the nature or definition of panic. And this happens usually in the span of about anywhere from 10 to 15 or 20 minutes. So the symptoms of a panic attack peak within that short time frame. And like I said, the panic disorder is the experience of a panic attack and the fear around experiencing another panic attack, and the fear making you change your behavior, if you will, and avoiding circumstances. There's agoraphobia, which used to be a supplement to other anxiety conditions, and in specific panic disorder, and we'll talk about that in a second. But agoraphobia in the DSM-5 is now a bona fide diagnosable condition. And this is a condition where you have marked fear or anxiety about being in public places. And in fact, that coincides with the word agoraphobia, which comes from the Latin meaning fear of the marketplace. Okay, So agoraphobia, according to the DSM-5 criteria, is marked fear, anxiety in being in conditions such as using public transportation, being in open spaces, being in enclosed spaces, being around crowds, waiting in line, for example, being outside the house generally. And there's often a change in behavior as well. So you start avoiding these circumstances, going out of your way to not encounter such circumstances. And the situation, or even the thought of the situation, often provokes an intense fear. So even thinking about being in a public space or standing in a crowd or in a line creates a lot of anxiety. And evidence shows that people with agoraphobia actively avoid these situations. Okay, so not only that even the thoughts or the situation themselves bring about a lot of anxiety, the anxiety makes them more likely to avoid such circumstances. And of course, like other anxiety conditions, the fear is out of proportion with what exactly is happening in the environment. Okay, so the reason why agoraphobia was very much associated with panic disorder in previous versions is because these two conditions are often comorbid at a very high rate. So people with panic disorders, right? So people with who suffer from a panic disorder proper in accordance with the DSM-5 criteria, they often avoid public spaces, such as using public transportation, etc., in the fear that they might have a panic attack during those circumstances. And for that reason, panic disorder and agoraphobia tend to be highly comorbid conditions, because people with panic disorders often avoid public places or places where there are a lot of people congregating out of the fear that they might have a panic attack during these situations, which might make them more embarrassed or might make it very difficult for them to escape. Social anxiety disorder, or social phobia as it is called, according to the DSM-5 criteria, is defined as having this intense fear of social circumstances or social situations, typified by the fear of you being scrutinized by other people. So, being observed as you eat, for example, in public, having a conversation, etc. So the hallmark feature of social anxiety disorder is the fear of making a fool of yourself during these social circumstances, okay? Or that you'll make a mistake that will be catastrophic, etc. And for that reason, people with social phobia or social anxiety disorder go out of their way to avoid social situations entirely, if you will. Okay, again, out of the fear that they might be humiliated or negatively evaluated in some way. So the social situation that is the object of the fear is almost always provokes an intense fear reaction. And this intense fear reaction sometimes makes people, again, go out of their way to behaviorally avoid anything that is related to a social gathering, if you will. And like the other conditions in the DSM, social phobia or social anxiety disorder also has a time specifier, and the symptoms here need to last 6 or more months. Obsessive-compulsive disorder, which used to be part of the anxiety disorders category, but now it is a separate category altogether, but it is an anxiety-related condition. But obsessive-compulsive disorder, according to DSM-5, is the experience of either obsessions or compulsions, and more often than not, both. But in order for you to meet diagnostic criteria, you have to either show obsessions as is defined here, or compulsions. But like I said earlier, oftentimes people present with both. And obsessions, or an obsession, is defined as these unwanted or intrusive recurrent thoughts. And these thoughts are often accompanied by a great deal of anxiety. And I'll give an example. The thoughts could be about some kind of contamination when you touch something that you perceive as being contaminated. Okay? So the thought of germs on your hand and your hand being contaminated with such germs creates a whole lot of anxiety amongst someone with a diagnosable obsessive-compulsive disorder. and the individual tries everything they could to try and suppress or avoid that obsession, that thought, that recurrent intrusive thought. But because of the nature of trying to suppress something, the more you try to suppress these negative or these intrusive thoughts about contamination or disorderliness, the more these thoughts are actually available or present in the mind. Because, of course, the more you try to suppress something, the more of a rebound effect it has. So obsessive-compulsive disorder is the experience of either obsessions, or these recurrent thoughts, or compulsions, or repetitive behaviors or mental acts, if you will, that are done solely to reduce the anxiety experienced by that obsessive thought. Okay, so if you have fears of or intrusive obsessional thoughts about being contaminated, for example, your hands being contaminated, the compulsive behavior would be a repetitive behavior in the form of, for example, washing your hands repeatedly to try and rid you of the anxiety of having the obsessional thought to begin with. And oftentimes these compulsions are extremely time-consuming, extremely. It takes several hours a day for people to do, and they often become, as the disorder progresses, unfortunately, these obsessions and these compulsions specifically become extremely elaborate over time. And I'm going to challenge you to stop the video right here to watch this video, this embedded YouTube clip that shows you what it's like to live with obsessive-compulsive disorder and how debilitating of a condition that is. And of course, all the conditions that we talked about, given the nature, the diagnosable nature of them, okay, they're all extremely debilitating. And in fact, I'm not showing you the entire DSM criteria here when we discuss generalized anxiety, when we discuss panic, agoraphobia, social anxiety disorder, and then finally obsessive-compulsive disorder. But one of the major criteria in all of these conditions, both anxiety and mood disorders, is that people experience some kind of a dysfunction, meaning they're impaired to do their work, or they're impaired in their family duties, for example, or they have to show a great deal of subjective distress. They're telling you they cannot tolerate these symptoms, and these symptoms make them feel very, very bad. Okay, so oftentimes that is extremely true of all of these conditions. Here are kind of typical or very commonly seen obsessive thought patterns and compulsive behavior patterns. So, for example, if the obsessive thought is about your hand being dirty, your hand being contaminated by germs, a compulsive behavior might develop around that particular obsessive thought, around washing your hand more than one time, or going through a ritual of washing your hand. Similarly, if you have repetitive thoughts about the door being unlocked or the stove not being turned off, there could be a ritual there, a compulsive behavior pattern that is conducted to reduce the anxiety around that particular obsession. And that is often in the form of rechecking the door multiple times, maybe 3 times, or checking to see if the stove has been turned off multiple times. Okay? And sometimes we see a sexual or religious flavor, if you will, to some of these obsessive thought patterns. And sometimes this particular theme of obsession, so sexual or religious thoughts, the ritual associated with these also takes the form of a religious or spiritual kind of ritual, if you will. So these mental rituals are often include prayer or repeating certain words that are associated with a religious meaning or a religious symbol. Okay, so the obsessions can take on a lot of different forms, and the compulsions or the compulsive behavior is typically intended to reduce the anxiety associated with having the obsessive thought to begin with. Post-traumatic stress disorder, which we talked about briefly in our lectures on stress coping and health. So according to DSM-5 criteria, in order for people to be diagnosed with post-traumatic stress disorder, PTSD, they have to be exposed to some kind of a traumatic event. And traumatic event, if you remember, are these extremely stressful situations, or they're extreme stressors, where there's some kind of an actual threat of death, or some kind of a threat of one losing one's life, or some kind of a witness to serious injury, or being unfortunately experience some kind of sexual violence. So this could be direct, so you could be experiencing these things or this particular traumatic stressor yourself, or you could witness someone experiencing something like that, or even hearing about a trauma is enough to trigger the symptoms of PTSD here. And when someone experiences such traumatic events and they're showing DSM-5 criteria of post-traumatic stress disorder, the experience of the traumatic event is usually accompanied after that experience with a number of psychological features, if you were. One of the criteria for meeting diagnostic criteria for PTSD, what are the criterions, if you will, is the experience of intrusive thoughts. Okay, so at least one intrusive thought-related symptom needs to be present for someone to have a PTSD diagnosis, and this comes in the form of memories and flashbacks, if you will, of that traumatic event. There's avoidance symptoms. Okay, so you need one of these to meet diagnostic criteria. And this is avoidance of anything related to that trauma that you experience, or any kind of external cues or reminders of that trauma. There are, of course, negative changes in one's thoughts and one's moods, so having predominantly negative affect, exaggerated blame of self or other people. And then finally, there are also a set of symptoms related to alterations in arousal and reactivity. So you're hypervigilant, meaning if you're meeting diagnostic criteria for PTSD, or if you have this particular symptom of PTSD, someone who taps you on the shoulder, for example, it may be enough for you to jump in a exaggerated startle response, if you will. Okay, so that's what hypervigilance means. And of course, the condition is also accompanied by difficulties in sleep and concentration and irritability, etc. So that's post-traumatic stress disorder, DSM criteria. And here's the overall prevalence of anxiety conditions, and this is, I believe, North American estimates. Okay? And depending on what measure you're using, depends on what kind of criteria you're using, whether DSM-5 or previous versions of the DSM, you'll get rates that look pretty much like this. So panic disorder, 12 months rate is about 1% of the population, if you will. Lifetime a little bit higher than that, 1.6. These are different surveys that have been conducted. And again, depending on what criteria and what questions the surveyors are asking, you'll get different rates of these different anxiety conditions. But overall here, the 12 months prevalence of all anxiety conditions, according to this particular study, the ECA study, is about 10.1. And if you zoom out people's lifetime, it's close to about 15%. Okay? So let's talk a little bit about some of the etiological models, or models related to causal factors associated with anxiety and related conditions, as well as let's talk about treatments that have been conducted to deal with or help patients who meet diagnostic criteria for some of these anxiety conditions. There is now lots of research evidence to suggest that genes play an important role in the development of anxiety and related conditions. We know, for example, from a lot of twin and family studies and genetic studies, that if a genetic relative develops an anxiety condition in their lifetime, the chances of another genetic relative in that family to also develop an anxiety condition is much, much higher than the chances to develop an anxiety condition if they're from the general population, meaning there is a genetic link here, or genetic factor that predisposes people to developing anxiety and related conditions. And we also know that the closer the genetic relativity, meaning, for example, that monozygotic twins or identical twins that share 100% of their genes, the correspondence in the levels of anxiety between the two identical twins is much higher than the correspondence of anxiety disorders between fraternal twins who only share about 50% of their genes, meaning that the closer the genetic relativity, the higher the chances of people developing an anxiety condition. So genes are clearly implicated. So have studies showing that there are chemical abnormalities also associated with the development of anxiety conditions. And one of the major theories of chemical abnormalities related to the development of anxiety conditions is this GABA inactivity theory. And GABA is a particular neurotransmitter in the brain that has inhibitory powers, meaning that it slows down, so the more of it in the brain, the slower the central nervous system becomes, and the slower the rate of firing in the central nervous system, okay, which is obviously has an anti-anxiety or anxiolytic effects. And the way to think about GABA here, and this is the way I like to describe GABA, is, we've all experienced driving on the road, and sometimes we go over the speed limit a little bit. What happens if you're driving and you're slightly over the speed limit and you see a cop car driving next to you? Chances are you'll probably slow down a little bit, and chances are everybody in traffic will also slow down if they witness the cop car driving next to them. And that's basically the role of GABA, if you will. GABA is that cop car that slows down all kinds of activity in the brain. And the GABA inactivity theory basically says that people who are prone to anxiety conditions have less of this inhibitory neurotransmitter in their brains. Given this genetic and chemical link, there have been several biochemical interventions developed for anxiety conditions that show relatively good efficacy and effectiveness rates. So there's lots of anti-anxiety or anxiolytic related treatments. Barbiturates are sedative hypnotics. Again, the role of barbiturates is to slow down central nervous system firing, if you will, so it works quite well as an anti-anxiety medication. However, it's not really very well used given the highly addictive properties of barbiturates. So for a very long time now, we've been using benzodiazepines, such as Xanax and Ativan. And benzodiazepines are directly related to GABA, the neurotransmitter GABA. So if you take benzodiazepines, it increases GABA activity in the brain, meaning it increases that level of that inhibitory neurotransmitter, which makes people feel less anxious. That too is also highly addictive, benzodiazepines, that is. And for that reason, if you are on medication for a very long-term basis, if you're suffering from an anxiety condition, typically speaking now, physicians and psychiatrists will prescribe SSRIs, or selective serotonin reuptake inhibitors, which are actually a form of antidepressant medication. And the research is actually showing us that SSRIs work very well as long-term medications for all kinds of anxiety conditions as well, not just depression. Here's the behavioral model of obsessive-compulsive disorder. And we talked briefly about obsessive-compulsive disorder as this condition where people experience either severe obsessions in the form of intrusive thoughts related to contamination, disorderliness, related to sinfulness, and or the experience of compulsions, or this ritualized behavior that is specifically intended to reduce the anxiety-provoking effects, if you will, of the obsessional thoughts, the intrusive thoughts that you're having a hard time controlling if you're diagnosed with obsessive-compulsive disorder. Okay? Sometimes these things develop completely through what we call illusory correlations. It's when patients notice a relationship between their behaviors when none actually exists. So somebody with an obsessive-compulsive disorder, for example, may believe that, out of the 1,000 times that I washed my hands when I felt contaminated, I didn't get sick. Therefore, washing my hands excessively as I do prevents me from getting sick. And therefore, that behavior gets stuck, gets reinforced because you believe that there is some kind of a connection here between your hand-washing behavior and the fact that you didn't get sick the last 1,000 times you washed your hands. Okay, so that's a purely behavioral model of why people may develop compulsions and or obsessions and then later compulsions, for example. One of the most successful treatments in obsessive-compulsive disorder is something we call exposure and response prevention, which is when people actually are encouraged to think of their obsession or have the obsessional thought and then resist the urge of actually doing the compulsion. And this is to break the cycle between having the obsessional thoughts and doing the rituals to reduce the anxiety associated with the obsessional thoughts. Okay? So overall, if the system is not broken, it's reinforced. So you never really get to question the belief that if I don't wash my hands, I might get sick. And for that reason, we try to help patients through exposure and response prevention to have to experience the contamination, for example, to put their hands in dirt and then do nothing about it, which is completely not like what they've been doing for the last little while that they've been experiencing OCD symptoms. And typically speaking, exposure and response prevention is associated with anywhere from 55 to 85% of people who do exposure and response prevention for obsessive-compulsive disorder no longer meet diagnostic criteria for the condition. Okay, so it's one of the most successful treatments of obsessive-compulsive disorder that we have. Comes in the form of a behavioral intervention, which is basically rests upon exposure. So exposing people to the very things that they fear. Of course, there are cognitive models of anxiety generally, but here is an example of how cognitive models work for social anxiety or social phobia, for example. So people with social phobia or social anxiety disorder typically experience thoughts or interpretations of the world that are typically speaking negative, or they're catastrophic in the way they interpret their future. So they believe, for example, that they have to be perfect in all social situations. They believe that if people only saw them for who they are, they see how unattractive they are, whether it be personality or physically, if you will. If people had a chance to look at or evaluate their social skills, they'll find that they're deeply wanting. So all of these beliefs tend to exacerbate the fear, as you can imagine, that is experienced when somebody is in the context of a social situation who has a social phobia or social anxiety disorder. So there have been a number of other cognitive models or cognitive perspectives to try and understand other psychological conditions. So, for example, there is a particular cognitive model of generalized anxiety disorder, and that is pretty much related to the types of thoughts that you have about the worries. And according to a very well-known psychologist by the name of Adrian Wells, he called it the metacognition theory of generalized anxiety disorder, where people's evaluations of the worry, people's interpretations of the worry, may actually maintain the condition. For example, if you believe that the excessive worry that you have, if you're diagnosed with a generalized anxiety disorder condition, if you believe the excessive worries that you experience are actually beneficial to you somehow, that they prevent problems from occurring later on, that they prevent you from making mistakes, then it's probably a lot more difficult to get rid of these worries because you believe they serve a positive function. And that is exactly what Adrian Wells's metacognition theory says, is that how you evaluate the symptoms of generalized anxiety disorder themselves may actually exacerbate or maintain the psychological condition. And then there is another very known theory, and this it expands not just for generalized anxiety disorder and panic, but it also expands or is a common theme in many, many different anxiety conditions, which is this intolerance of uncertainty, which is this, complete distress or having a very low tolerance for situations where you don't know or you don't have all the data in hand. Okay, so we call that intolerance of uncertainty. It's when you don't have enough information and you just cannot tolerate that state of not having all the information or all the important information. And it plays a very important role, we find out, in generalized anxiety disorder, because, again, you have to think of the excessive worries that people with generalized anxiety disorder exhibit or show as the brain's way of trying to make sense, of trying to find information, of trying to predict patterns, etc. When, of course, oftentimes this information is impossible to gather because it's about a future event. Okay, so intolerance of uncertainty plays a huge role in both generalized anxiety disorders as well as panic. But some recent research, and in fact research coming out of the University of Regina, researchers such as Dr. Nicholas Carlton has done a lot of work on this idea of intolerance of uncertainty, and to him and to other people, this concept is actually what we call a transdiagnostic concept, which means that it relates to the development of a bunch of other anxiety conditions, in fact, all of them, according to Dr. Carlton, and it may actually play a role in the development of something like unipolar depression, which we will talk about at the end of this lecture. So based on these cognitive models of psychopathology, there have been several treatments that have been recommended for anxiety conditions. And the point of these treatments really is to help patients identify and challenge or dismantle irrational or maladaptive beliefs. Okay, so if you have social anxiety and you believe that you have to be perfect in all social situations, the therapist and the patient working together in cognitive behavioral therapy would identify this negative cognition and would help patients rework that interpretation or that cognition so that it's a lot more flexible and it's a lot more adaptive. Of course, they'd work on the thought that one must be perfect in social circumstances. Well, what does perfect actually mean, for example? And why is it important for anyone to be perfect? Is it even possible for anyone to be perfect? And does anyone care if you're perfect? So these are the types of things that patient and therapists work on in the context of cognitive behavioral treatments for social anxiety, for example. And also, cognitive therapies have a very educational component to them. So part of the therapy is actually educating clients about the role of anxiety and the role of worry in people's lives. And part of the treatment is also related to giving people skills to learn, monitor their own thoughts and help dismantle or argue against or challenge these negative automatic thoughts. Okay. In the context of cognitive therapy, we also do a lot of behavioral work, and one of the most important components of behavioral work is to do exposure treatment. Again, very similar to what we talked about in O.C.D. Exposure treatment is we expose people to whatever it is that they fear, whatever it is the theme of their anxiety condition, whether it be social anxiety, whether it be panic. We expose people to these very things that they're afraid of. If it's panic, for example, we induce a panic attack. Because again, that is the very thing that people are worried about, and that is the very thing that they avoid, and therefore, whatever beliefs or interpretations they have about that thing that they fear never actually is challenged at all environmentally, because you avoid all situations where you would be challenging these cognitions. So you go on living with the belief that you won't be able to cope if you're in a social circumstance. If things go wrong in that social circumstance, it'll affect your entire life. So these very negative, exacerbating beliefs become challenged, if you will, if you meet the thing that you fear head on. And in doing so, in helping people become exposed to the things that they fear, we also look out for what we call safety behaviors, which are these kind of really small behaviors that people do to try and manage the anxiety, which tend to mask the effects of the exposure therapy itself. Okay, so if you have agoraphobia, for example, one of your safety behaviors when you go out and you're doing exposure therapy, which, of course, if you're doing exposure therapy for agoraphobia, one of the things you'll probably be asked to do is be out in a very crowded place and sit with that fear, if you will, until it subsides, which of course it will over time, as many studies have shown us. So one of the things that you could be doing as a safety behavior, if you're doing that particular exposure exercise, is to have your anxiolytic medication in your pocket just in case. So this gives you kind of a sense of comfort and sense of safety. That's why we call them safety behaviors. But unfortunately, some studies are showing that if you do safety behaviors in the context of exposure, it may actually reduce the effects of exposure therapy a little. So we do, in the context of cognitive treatment, also behavioral treatment, we look out for these little tiny safety behaviors that may be kind of suppressing the effects of exposure. I will challenge you to stop the video here and watch the embedded YouTube clips. You'll find them embedded in the lecture slides that are associated with these videos. And I want you to stop and watch as people in these clips go through a form of exposure. We call them systematic desensitization. And in vivo desensitization is exposure, or kind of encouraging people to be in contact or come in contact with the fearful object in real life. This is happening live. So if you're afraid of spiders, for example, then you'll go to a pet store and look at a spider. That's called in vivo desensitization because it's happening in real life. There's another form of exposure or systematic desensitization, and that's called covert desensitization. That's when you imagine the fearful event, so you write about it or you imagine it as much detail as possible, and that's often used in things like post-traumatic stress disorder because, of course, we cannot expose people to the traumatic event again. That would be very, very unethical. And the key to success here is, as mentioned multiple times in exposure and systematic desensitization, is the actual contact with the fearful object or the situation itself. And as we develop technologically, we are starting to expand how we could do exposure therapy to help as many people as possible. One of these recent expansions has been in the realm of virtual or the use of virtual reality as a tool for exposure therapy. So there's another video here that shows you how that has been done over the last few years. And it has there's been a few studies now on the effectiveness of exposure therapy with virtual reality, which shows that it can actually be quite effective as a tool to battle some of these phobias and anxiety conditions. Okay, so systematic desensitization, just so you know, was developed by a researcher by the name of Joseph Wolpe. So now that we've discussed some of the theoretical models around the developing anxiety conditions as well as some of the treatments for anxiety conditions, let's look at another category of disorders in the DSM that is very much related to anxiety, and these are the mood disorders. And the first thing that we will discuss is we'll get a few definitions out of the way here. Depression, as is used in these slides as well as used in the DSM, is any period of low mood that is typified by some kind of a withdrawal from the environment, if you will. Okay, so that's a depressive period. Mania, on the other hand, is the opposite of a depressive period. Is a period where you experience extreme euphoria, increased energy, exaggerated, grandiose beliefs about who you are and what you're capable of doing. Okay, so that is a manic episode. Unipolar depression is typified by the experience of only depressive states or depressive periods, with no history of mania. So no history of those periods where you're feeling that euphoria, increased energy, etc. And bipolar disorder, by contrast, is a disorder typified by cycling between depression and mania, especially bipolar 2, which is typified by the experience of depression and some kind of a hypomanic episode. And we'll discuss what these terms mean later on. In bipolar 1 disorder, you don't necessarily need to show a depressive episode in order for you to be diagnosed with bipolar 1. But the presence of mania needs to be there for a bipolar disorder diagnosis. Pretty much everyone that I know of has experienced a period of low mood or sadness. So this experience of sadness is very much evolutionarily adaptive and very, very normative. And in fact, it's a very common reaction to the experience of some kind of a loss. Okay, so it's the job you didn't get, or the relationship that never worked out, etc. And of course, there is an evolutionary reason why we experience sadness. Okay, so much like anxiety, at one point in our evolutionary history, it was beneficial for us to experience this level of sadness and social withdrawal, because it provided us with some time to recuperate our lost resources, basically licking our wounds and thinking of a way forward, if you will. Okay, so that was perhaps the evolutionary function of depressive states. However, when someone is experiencing clinical levels of depression, so if they're experiencing clinical depression, this period of sadness and social withdrawal and loss of pleasure in things that you usually enjoy lasts much, much longer, and it's much more severe than you would see in normal depressive states or normal sad states, if you will. And so the duration is much longer, the intensity is much more intense, and it's disproportionate to whatever the loss may be. Okay, so even though it was evolutionarily adaptive, very much like anxiety, people who experience clinical levels of depression often describe these very, very debilitating levels of sadness. So it can bring about really severe and long-lasting psychological pain, if you will, as well as causes a number of significant functional impairment. And people who experience the symptoms of clinical depression will also tell you that it's extremely distressing to have these symptoms. I challenge you to stop the video here and go to your slides and watch this embedded YouTube clip of that I have in this particular slide. And this YouTube clip will discuss what it's like to have unipolar depression, if you will. So it's a patient describing their symptoms of unipolar depression. Here is the DSM-5 criteria for major depressive disorder or major depressive episode. And I think you've seen these in the past, as I've used them as illustration of the heterogeneity of symptom profile issue that we talked about in the first lecture. But here they are again. So according to the DSM, if you are to meet diagnostic criteria for a depressive episode, you have to be showing 5 or more of the following in a 2-week period. And the symptoms must be present for more days than not in these 2 weeks. And you have to, one of the 5 symptoms that you experience have to be one of the very first 2, which is, the experience of a depressed mood most of the day or nearly every day, or the experience of anhedonia on most days, or the loss of pleasure in things that you usually enjoyed, or previously enjoyed, that is. And here's the prevalence of unipolar depression, or how often it strikes the general population at any given time. So if you go out right now and give people a diagnostic test or measure of depression, you'll find that about anywhere from 1 to 2% of the population right now, today, it's about 5,000 people who live in Regina, just to put that in perspective, will have a diagnosable clinical depressive episode. Okay, so that's about 1.5% of the population. In Canada, close to about 12% of the population will experience some kind of a depressive episode at some point in their life. So again, if you zoom out and look at the entire lifeline, about 11 to 12% of people will experience a depressive episode. And you'll notice here that women are twice as likely to experience or develop depression than are men. Okay? And there are several reasons for why that is, and we will discuss some of these reasons in the next lecture. But a person who has, and this is really the tragic part about clinical depression, is that if you experience or develop one episode of the condition, it's a highly chronic and recurrent condition, which means that on average, people go on to develop 4 to 5 episodes in a lifetime. There's something about the condition that makes it reoccur over time. And we know from some literature or some research that the very first episode, typically speaking, appears in late adolescence or early adulthood, a time that is particularly stressful for most people. But with that all said, anyone at any age can experience unipolar or major depressive disorder. Bipolar disorder is different from unipolar depression in that in bipolar disorder, and there are 2 types of bipolar disorder, bipolar 1 and bipolar 2, but in both of these categories in the DSM, you have to experience at least one manic or hypomanic episodes. So it's not just the experience of a depressive or sad episodes. The depressive or the sad episodes are intermixed with episodes of mania, and we will discuss what mania looks like here in a second. And typically speaking, the manic episodes are less frequent in bipolar disorder, and they're much shorter in duration than depressive episodes in the same disorder. So here's the criteria for bipolar 1 disorder, and as you'll see, with bipolar 1 disorder, you have to experience at least one full-on manic episode. And you may or may not experience a depressive episode, but typically speaking, people do develop both types of episodes in a bipolar 1 diagnosis. But to meet diagnosis, you only have to show evidence of the full-on manic episode. And the manic episode is a period of very elevated, expansive, or irritable mood, if you will. The grandiose beliefs about, discovering the cure for cancer, for example, whatever you may think of. And that typically lasts about a week or more, and it's present for more days than not. And during this period of mania, you'll experience more than 3 of the following. Okay? This is inflated self-esteem, or again, grandiose ideas, decreased need for sleep, pressured speech, racing thoughts, so on and so forth. Here is the DSM-5 criteria for bipolar 2 disorder. So in bipolar 2 disorder, you don't need to experience a full manic episode. What is necessary here for you to meet a bipolar 2 disorder is the experience of one hypomanic episode. And in fact, if you experience the full manic episode, the diagnosis is probably more in line with a bipolar 1. And in fact, bipolar 2 disorder says you cannot experience any full manic episodes. So you have to have at least one hypomanic episode. And basically, a hypomanic episode is not as severe as a full manic episode. So you may be showing some of the same signs or symptoms of a hypomanic or a full-on manic episode, but they're just simply not as severe. And they don't last as long, typically speaking. So anywhere from about 4 to 7 days is when you're showing symptoms of a hypomanic episode. So in bipolar 2, you have to experience one hypomanic episode and one major depressive episode. So remember, bipolar 1, full-on manic episode, and you may or may not experience a depressive episode. In bipolar 2, one hypomanic and at least one major depressive episode. Here's what a manic episode looks like, the fuller criteria for that. So often it begins very abruptly. And as mentioned time and time again, people typically talk about the experience of very, very large amounts of energy, if you will. They're very sociable, and they often make very impulsive or poor decisions. They speak very rapidly. Sometimes we call that pressured speech. There's often flight of ideas, so the mind keeps shifting from one thought to another. There's an inflated sense of self-esteem, or what you could do for the world, or who you are, for example. And you take on more things than you can handle during a full-on manic episode, and to a lesser extent a hypomanic episode. Sometimes people don't really think about the consequences of their behavior because that is the nature of a manic episode. And sometimes particular hallucinations or delusions are possible, even though hallucinations and delusions are more typical of schizophrenic disorders. Here is the annual or past year prevalence of bipolar disorder among U.S. adults. This is a relatively dated data set, but as you can tell, it decreases with age, but fairly even sex split, right? So about 3% of the population overall, and there are no sex differences in terms of who's more likely to develop it. So it's a bit different from unipolar depression, which tells us that women are twice more likely to develop depression. So the chances of you developing a bipolar disorder decreases with age, as you can see here in this graph. Let's talk about some of the etiological models or theoretical perspectives, as well as treatments for unipolar depression and later on bipolar disorder. So much like depression, genes have been heavily implicated in the study of unipolar and bipolar depression. We know, for example, that the concordance rates of a depressive episode between monozygotic twins is close to 50%. Remember, in the general population, the chances of someone developing a depressive disorder in a lifetime is about 11%. So this is about almost a 5 times increase if you're very, very genetically related to the person, which tells you that genes are obviously implicated, especially if you compare that 46% amongst identical twins with the 20% amongst fraternal twins. So clearly here, the higher the genetic relatedness, the higher the chances of developing a unipolar depressive episode amongst these twins. So if one identical twins develops it, 46% of the other twins will also develop it, and so on for the fraternal twins. So clearly genes are implicated, but they're not everything in unipolar depression. And in fact, some adoption studies are confirming this role of genes in the development of unipolar depression, especially amongst severe forms of unipolar depression. So it looks like there's more of a heavier genetic component, especially when we're looking at unipolar severe forms of depression. And there have been several specific genes or a number of genes that have been associated specifically with unipolar depression. One of which is this 5-HTT-LPR transporter gene, which works to transport the neurotransmitter serotonin across the brain. So some evidence that has shown now abnormalities in this particular gene and the later development of unipolar depression. Although there have been recent research showing that this association with the 5-HTT-LPR transporter gene and unipolar depression has been exaggerated over the years. So it may be a factor, but not as big as we thought. However, overall, the picture is clear. Genes do matter in the development of unipolar depression. For that reason, and based on an accidental discovery, which showed us that people at the time who were taking blood pressure medication, so they're taking medication to control or reduce their high blood pressure, which typically speaking lowers neurotransmitter activity in the brain, especially lowering serotonin and norepinephrine levels in the brain. But the evidence around the time was showing that people who do take these medications that lower these serotonin and norepinephrine levels actually show increased depressive symptoms, which tells us that particularly serotonin and norepinephrine are connected with depression. So the activity of these two neurotransmitters may be associated with the development of depression later on. And that kind of gave researchers this evidence that people taking high blood pressure medication are experiencing heightened depressive symptoms, gave researchers at the time impetus to start developing antidepressant medications that particularly work on increasing these two neurotransmitter activity in the brain, serotonin and norepinephrine. Okay. We also know from other research that suggests that there have been abnormally high levels of cortisol in the bodies and the saliva of people who experience unipolar depression. Again, and if you remember, cortisol is a stress hormone. Again, all of these are bits of evidence to suggest that there's some kind of a biochemical connection between neurotransmitters, these different chemicals in the body, and depressive symptoms. So for that reason, there have been several treatments that have been developed that work on this biochemical connection that relates to depression. And for the most part, there have been 4 classes of antidepressants. And the mechanisms of these antidepressants, for the most part, is very much on increasing the levels of particularly serotonin in the brain. And the first set of antidepressants that were developed were called tricyclic antidepressants. And they have a remission rate of about 50%. Monoamine oxidase inhibitors are also another class of antidepressant medications, and these are MAO inhibitors, monoamine oxidase inhibitors, work by increasing serotonin through reducing the breakdown of serotonin. Okay, so they inhibit a particular neurotransmitter in the brain that breaks down serotonin. So if you reduce the thing that breaks down serotonin, you increase serotonin in the brain, of course. The newer classes of antidepressant medications include things like selective serotonin reuptake inhibitors, SSRIs. We'll talk about the mechanisms of that when we get to the treatment unit of our lectures. And the very, very newest class of selective reuptake inhibitors, and we call those serotonin norepinephrine reuptake inhibitors, SNRIs. And this not only increases serotonin levels in the brain, but the SNRIs also increase norepinephrine levels in the brain through the disruption of the reuptake process for both of these neurotransmitters. Again, we will talk about these mechanisms in more detail in the psychological treatments unit. Let's talk more about cognitive theories of unipolar depression. There have been several cognitive theories that try to account for the development of unipolar depression over the years. One of the most influential has been Marty Seligman's learned helplessness theory of depression. So it's Abramson and Seligman who came up with this learned helplessness or attribution theory of unipolar depression. And this particular model is based on a set of studies that Seligman and colleagues conducted with dogs at the time. And what they did was they randomly assigned dogs into two conditions. In the first condition, the dog is to experience a shock. They're placed in an apparatus that looks very much like this, and they experience a shock on one side, yet they can easily escape the shock by jumping to the other side. Okay, so that's one condition that these dogs are randomized to. Another group of very similar dogs, very genetically similar dogs, were randomized to another condition that looked like this, except there is no relief from the shock. So even if you jump to the other side, the shock persists, if you will. Okay, so one set of dogs that can escape the shocks, and another set of dogs that, no matter what they do, they cannot escape the shock. And then they took both dogs in both of these conditions and put them in a situation where both of which can actually escape the shock. And of course, as you can probably imagine, the dogs that learned that you can escape the shock by jumping to the other side were way more likely to do that than the dogs that had learned that there is no escape from their shocks. And in fact, what the dogs that have learned that there is no escape, what they did was they just simply took the shock and they whimpered. And it's obviously very, very sad to hear that about dogs, but that was the zeitgeist of doing research, animal-related research at the time. Okay, and it brought us important discoveries about the nature of depression, if you will. So the concept here is the dogs that learned that they cannot escape the shock learned what Abramson and Seligman called, they learned helplessness. They learned to be helpless in situations that escape may actually be possible from. So, based on what they learned from past experiences, they create an interpretation of the world. Okay, and the interpretation holds three important themes, if you will, that people who are more prone to depression have. Typically speaking, people who are more prone or more vulnerable to depression, according to Seligman's learned helplessness theory, will make internal, global, and stable attributions to instances where they failed. I'll give you an example of what that is. So let's say someone who is more prone to depression does an exam and fails that exam. They are more likely than people who are not vulnerable to depression to say, for example, that they failed the exam because they're stupid, an internal factor. Okay, so they say, I failed because I am stupid, which is, of course, an internal factor. They say, not only did I fail this exam, I'm going to fail all kinds of exams. So you make a global attribution. Okay, so you say that, in fact, that the failure is not context specific. It happens on a global level. It's gonna happen in other circumstances as well. Finally, people who are more prone to depression, according to learned helplessness theory, make stable attributions about failure as well. So they say, not only is it due to an internal cause, not only is this something that's going to keep happening, it's something that will be with me forever. I can't get rid of my stupidity, for example. Therefore, I can never pass an exam because I'm always going to be stupid, and this is always going to be a problem for me. And if you have that interpretation, according to learned helplessness theory, you do develop these perceptions that you cannot escape from situations, even when escape is actually possible. There's another cognitive, very, very dominant cognitive theory of unipolar depression that's around, and we call this Beck's cognitive theory of depression. And in Beck's theory, and Beck is known as one of the founders of cognitive behavioral therapy. And in fact, Beck was himself somebody who's trained in psychoanalysis. Okay? And so he's working with lots of patients at the time and trying to do research on psychoanalytic theory related to depressive patients and depressive symptoms. So he's seeing a lot of depressed patients. And what he found very early on in his work with patients with depression is that people with depression have a very, very negative way by which they interpret the situation. Okay, so for example, a friend will cancel lunch on them, and they will automatically think they canceled lunch because I'm unlovable. They canceled lunch because they don't like me. I'm no good. So this is what Beck and others later on called automatic negative thoughts. These are very quick, almost ingrained thoughts that lay just beneath the threshold of awareness, but they're accessible if you want to think about them, that kind of are associated with particular circumstances or particular situations that make you more likely to feel depressive symptoms. Of course, having the thought that you're unlovable is more likely to make you feel depressed in a context of a situation of a friend canceling lunch on you than a thought that maybe the friend is really quite busy nowadays. Okay, so again, from a cognitive theory perspective, interpretations that you make over events are very, very important in determining whether or not you may develop depression or anxiety later on, or other conditions, as the cognitive model, of course, has expanded beyond just anxiety and depression. So these are negative automatic thoughts, but according to Beck and other people, he kind of thought of our interpretive machine, if you will, our information processing system. He thought of it as existing in layers, okay? And the deeper down you go, the more you'll approximate something related to what Piaget talked about. So the deeper down into the information processing system you go, you will approximate something what he called a schema, which is, again, very similar to Piaget's idea of what a schema is, which are these heavy memory representations of concepts. So according to Beck, these schemas develop based on very early interactions in life, so very, very early childhood conditions and childhood environments predict what kind of schemas you will have about yourself, for example. And these schemas will branch out. So if it's a fairly negative self-schema, within the negative self-schema, you'll create rules for living or assumptions for living. Okay, and that's the next layer here. And the assumptions of living, if you're prone to depression, could look something like, if I'm not loved by everybody, then I'm no good at all. Okay? And you live your life as if these things are true, these rules are actually true. And then you have negative automatic thoughts, which is more kind of a surface level thoughts. And then the thing that maintains all three levels is what we call cognitive errors or cognitive distortions, which are distorted biases or distorted ways of looking at the world that exacerbate or maintain the other levels involved. So the schemas and the assumptions and the automatic thoughts. And I'll give you an example of what that might look like. So some people might have a particular cognitive distortion or error related to mind reading cognitive distortion. Okay, so that if I see somebody in the hallway and I say hello and they don't say hello back, it's because they hate me. Okay, so that we call it's a mind reading cognitive distortion, because somebody is making a statement about what that person must be thinking. They must hate me. They must think I'm no good. Okay, and that works to maintain the other levels, because if you just systematically thought that you are able to read someone's mind, and that's the interpretation you get from reading their mind, then the negative parts of your self-schemas are probably going to get exacerbated as well, and the assumptions are going to be more entrenched, so on and so forth. Okay, so the systematic errors that we make maintain this negative interpretive bias that we have in the information processing system. Okay, so that's Beck's cognitive theory of depression. It might look something like the following. Okay, so you have a particular life event that interacts with a core belief or a schema. So it creates a schema about being unloved, for example, if your needs are not met really early on in life, which then creates or is associated with a number of negative automatic thoughts and the way you actually interpret events around you, systematic errors in interpreting events, as well as these rules for living, these assumptions that we talked about. And all of these things, once activated, beget the emotions and the behaviors that are typical for depression, for example. And all of it's a very, very multi-directional type of model, meaning that the experience of these things later on as part of the information processing may actually exacerbate or make more salient negative features of the core belief to begin with. So it's a self-perpetuating system. It's a vicious cycle, if you will. There have been behavioral theories that have been forwarded to try and explain the development of something like unipolar depression. One of the major behavioral models of unipolar depression, it comes from a model from Lewinson, who's a very famous or very known behavioral scientist who works in the area of depression. And according to Lewinson and other behavioral theories, depression is typified by withdrawal from the environment. Okay, so you withdraw from the environment, which takes away from all the social reward that you have become accustomed to and that you need from an evolutionary perspective. Okay, so the more depressed you are, the less likely you are to seek out social rewards, and the less social rewards that you get, the more depressed you get, and the more socially withdrawn you get, so on and so forth. So from a behavioral perspective, how you break that cycle then is to actually inject positive activities and positive rewards right into people's lives. So you help them schedule in these very positive social and mastery-related activities. Social activities meaning maybe schedule in making time to see friends, even when you don't feel like it. And mastery activities would be scheduling in hygiene-related activities. And of course, people with depression, unfortunately, sometimes also the symptoms are such and so severe that they don't even take care of their hygiene. So even doing these, even scheduling these things that we even take for granted can be quite helpful for people who develop depression. And that is precisely what is predicted by something like the behavioral model of unipolar depression. So there's certainly a ton of research support that links the number of rewards people receive in their environment to how much depressive symptoms they're actually showing or exhibiting. Let's talk more now about bipolar depression. So etiological models or theories of the development of bipolar disorder, as well as treatments for bipolar disorder. So bipolar disorder, unlike unipolar depression, is very much a biologically dominant kind of disorder. So the biological and the chemical models in bipolar disorder are the ones that are dominant. In unipolar depression, the dominant models are, of course, behavioral and cognitive, as we spoke. But with bipolar disorder, the genetic models are more dominant. And again, much like estimates we see in unipolar depression, bipolar depression too seems to be something that quote-unquote runs in families. So there's some kind of a genetic link here that makes people more likely to develop bipolar disorder. And you can see this from twin studies. So if one identical twin develops bipolar disorder, there's about a 40% chance that the other twin will also develop bipolar disorder. This number goes down to about 5 to 10% in fraternal twins. So remember, fraternal twins only share about 50% of their genes, while identical twins share about 100% of their genes. Okay, so clearly, the closer the genetic relatedness, the higher the likelihood that you will develop a bipolar disorder, which typifies a much larger increase from the rates of bipolar disorder in the general population. So there's some kind of a genetic link here. Here is a small little graph that shows you concordance rates. So if you have a bipolar disorder and you're an identical twin, your other identical twin has about a 25% likelihood of developing a bipolar disorder condition and about a 45% chance of developing a unipolar disorder condition. That's in unipolar disorder. If you are an identical twin with a condition of bipolar disorder, the other identical twin has a 40% and higher chance of developing a bipolar disorder, while the other twin has about a, 1 or 2% chance of developing unipolar depression, whereas this number goes down much more in fraternal twins. So if you're a fraternal twin with bipolar disorder, the chances of the other twin developing bipolar disorder is somewhere around 5%. Okay, so you can see the stark differences in terms of genetic relatedness and how that affects both bipolar and unipolar diagnoses later on, depending on how much genetic relatedness there is between the twins and what kind of condition the index twin has. There have been several other biochemical models or biochemical theories as to why people develop something like bipolar or unipolar depression. One theory that kind of combines theories of both, if you will, or at least attempts to account for both bipolar and unipolar depression, is something called the permissive theory of mood disorders. And the idea behind permissive theory of mood disorders is the experience of low serotonin may actually be a gateway. So it could be a gateway for mood disorders, and depending on the norepinephrine levels in the brain, combined with the low serotonin levels, will produce either depression or mania. Okay, so the permissiveness theory argues that it is low serotonin levels that opens the door for some kind of a mood disorder, and depending on if norepinephrine is high or low, you will develop depression in the low condition and mania in the high condition. Okay, so low serotonin is kind of a constant in both depression and anxiety, and low serotonin combined with low norepinephrine will produce depression. Low serotonin with high norepinephrine might produce mania. Not much research in support of this particular theory. There's also other biochemical theories of bipolar disorder, one of which takes into account the role of ions. And ions are basically responsible for the firing of nerve endings. So it's the speed and the type of information being sent from one nerve ending to another. And in the ion activity theory of mood disorders, the idea here is the ions are somehow disrupted, so that within the cell of the sufferer, the ion is not doing its job, and that accounts for such things as depressive and manic episodes. There's evidence that there's irregularities in how ions are actually transported throughout the brain, and that depending on the problems with transporting ions throughout the brain, you may develop things such as mania or things like depression. So given the heavy biochemical component related to bipolar disorder, and given the heavier genetic component, much of the treatments that have been suggested for bipolar disorder so far have been in the form of biochemical treatments. Okay? So those psychopharmacological treatments developed to stabilize people's moods. So remember, bipolar disorder is typified by swings between sadness and manic episodes. So getting a mood stabilizer such as lithium, the research is showing us, helps people stabilize these mood swings. Antipsychotic medications have also been indicated for something like mania, and for both episodes of bipolar disorder, either be manic or depressive episodes. There's some evidence to suggest that antipsychotic medications that are typically given for people suffering from schizophrenia, for example, also works for people with bipolar disorder. And then finally, the antidepressant, the classes of antidepressant medications that we discussed, which typically work only for the depressive episode, have been prescribed alongside with mood stabilizers, again, to help people level off and break this cycling between depressive and manic episodes. Until next time.